Welcome to today's broadcast of North Idaho College Public Forum. The crew is comprised of NIC television students, and your moderator is North Idaho College political scientist Tony Stewart.
Today's topic is hospice. It's a concept that originated mostly in Europe and England in particular, and I know many of our viewers out there today are very familiar with this organization and this concept as it's grown throughout the United States. It's grown from just a very, very few hospice in the 1960s until 1988, when we have many such organizations throughout this country, and it's an organization that cares for the terminally ill. We're very fortunate to have on the program a very qualified person to discuss this topic and how it relates to that organization throughout the United States. I welcome to the program Kay Magruder. Her position is Executive Director of Hospice of North Idaho. She is also the President of the Council of Idaho Hospice Organizations, in which she represents all the hospice throughout the state of Idaho. She also is very active in what is called the National Hospice Organization. So as I indicated at the beginning, she is highly qualified to discuss this subject, and I'm also delighted to welcome her on the program. It's a very good friend, and I am looking forward to the interview, and welcome to our program, Kay.
Thank you, Tony.
Kay, I think that for our viewers who might not have the exposure that certainly some other citizens have had, that we should start at ground zero and work up on this concept. Would you share with the viewers what I introduced, how hospice started, or the concept, and I believe I'm correct that it started in England? Would you tell us that story and then how it came to the United States and grew in this country?
There was a nurse in England in the 50s that cared for patients primarily who had cancer, and saw that we were not, as a healthcare, looking at that person as a total person. And so she decided to approach the medical community, her peers, and make some changes. Well, she didn't find that possible as a nurse, so she became a doctor and found that that was the way in which she could do that. And so Dr. Cicely Saunders started the movement in about 1967. So as you can see, it's a fairly new concept, and it looks at all patients as whole people, looking at their psychosocial, their spiritual, as well as their physical needs. Their spiritual needs being defined by the patient as they choose. So it's not a denominational type of program that we have. In 1974, it came to the United States, and I'm very, very proud that in 1981, it came to Kootenai County. And I think that says a lot about our area and how progressive we are in wanting to really be a part of new things and trying new ways and new approaches. And so that made it possible for me to be part of that first movement. And at that time, I had a co-director, and we began, as I said, in 1981, and we were the third hospice in the state of Idaho to develop. And since there have been 19 others developed, and in the
that is in the state of Idaho.
In the state of Idaho, and in the United States, it has gone from one in 1974 to 1,600. So as you can see, there's a great movement towards hospice and caring for people at home.
And our viewing audience is much broader than Idaho, and so we can report that in addition to those 19 Idaho, the adjoining states, such as Washington, also have hospice. There's a very active hospice in Spokane, for example, isn't it?
Yes, very, very active in Spokane. And the person who started home hospice here, Dr. Bill Lammers, also went to Calgary and helped them set up their unit in, it's their palliative care unit is what they call it. And that was about 6 years ago that he started that there.
Yes, our program does go into Canada, so there's a number of them in Canada. Isn't there also a regional organization as well? There's something called the National Hospice Organization in the country, but then you have regional organizations within that, and isn't that quite active in the Northwest?
Yes, I think we have probably the most active regional organization around the United States, and that encompasses Oregon, Washington, Idaho, Montana, and Alaska.
Yes. Now, with that exciting background that it is prospering, and I think we can compliment the people of this area that since it only started in 1974, it wasn't very long to come to the Northwest. We weren't very far behind. But as someone who's been involved with hospice for some years, I'm very impressed with the concept. You mentioned briefly the different aspects, but let's talk about some of there's a set of, I guess I would call them principles or dogma of hospice that all hospice organizations must adhere to be a hospice organization and belong to the national organization. Would you try to take us through some of those so our viewers get an appreciation of what are the principles of hospice?
Well, it is the majority of our care is done at home. However, we do follow the patient and their family regardless of where they choose that setting to be, whether that be in a hospital or a nursing home. And because one place, one setting is better for them one day does not necessarily mean that it will be best for them throughout that entire illness. We see all types of patients regardless of what disease process they have. Our youngest patient was 3 years old, and I know in some hospice programs they have small children, infants. And so there's not an age criteria. Our oldest patient was 96, so there's quite a variance in the age group that we serve.
I guess I'll interrupt to say you don't take just anyone who's ill. There is a criteria, though, for taking a person.
Yes, they have to have a life expectancy of 6 months or less. And that is certified by their family physician. Their family physician comes on board as the head of our team, and that's very important that the family physician stay involved. And then we act as an extension of his arm in making home visits and then giving him the feedback to help him care for his patient or her patient as well as possibly we can. So we work very closely as a team. We also, as a team, need to have not only doctors and nurses going into the home, but we also have social workers and physical therapists and occupational and speech therapists. So there's a whole team concept. We have ministers who volunteer to work with patients if they don't have a church affiliation of their home and choose to have our minister who's on our interdisciplinary team go into their home. So it's very much an interdisciplinary type of care. Different than traditional medicine is the fact that the patient and the family are the unit of care, and the patient being only but one member of that unit. So when the patient dies, hospice then follows the family with bereavement support, counseling, one-on-one or through group therapy for 2 years following the death.
But you also involved with helping in that area before the death because there's all that difficulty that they know that the member of the family is dying.
Yes, and
so you don't wait for the death to actually start counseling with the family.
Right. The social workers do the primary part of that counseling, but the grief counselor makes, we hope, at least one visit prior to the death so that she has or he has the opportunity to meet the patient prior to the death so that they have a sense of family and how each of the family members interact with one another.
Yes.
Another part of our philosophy is that there needs to be a nurse on call 24 hours a day, 7 days a week, 365 days a year, so that regardless if there is a problem with pain management or a psychosocial crisis at 3 o'clock in the morning or 3 o'clock in the afternoon, the staff will be as available for them regardless of what time that crisis happens, because we don't have a guarantee that between 9 and 5 the crisis is going to happen, and often that's not when it is. It's when people are alone and frightened in the middle of the night that often they just need someone to talk with and to be reassured.
In addition to the nurses on call, and of course the patient continues to be under the supervision of the physician.
Yes.
And you have talked about the bereavement and how that supports the whole family, but there's what I call the heart of hospice, and that is the caregiver, the volunteers. Would you tell us the role of that very important group in this care?
The volunteers in our program is our largest staff. They, as of this month, are 70 in number, and they do everything from office work to going into the home and working directly with the clients. I think that one of the things that we find most often is that they become almost like family members to the people that they are supporting during this time. They only have one family to work with at once, and then after the death of that family member, the family that they're working with, then they have to, and required by our standards, take 1 month off, so as sort of a time for them to recover from that death as well. I think one thing that's very important that shows to me how caring and loving those volunteers are is that often the family asks them to sit with the family during the funeral, that they become that close to the family. So I think that's quite a compliment to our volunteers.
And volunteers have such giving all the time that I know there are cases where even after the death, even though their care for the patient has ended, they still have that very close tie to the family, and oftentimes that continues on, doesn't it, even after the death? I mean, or they're friends of the family?
Often for years. And I think that that says something about the quality of caring that they have and give to the families too, is that it's more than just an interaction, it's really a relationship.
Yes. I really want to get to the another one of the hearts of hospice. I think they have many hearts within this wonderful organization, and that is, one might ask the question, if they're not involved with this organization, why is it so important that when someone is terminally ill and they've gone through all the treatments basically, or they've had the surgery, and there's no question they're not going to survive, what are the advantages of that person going under hospice and going home rather than staying in the hospital or being institutionalized in that sense? I know the answer to that, but I do want you to be the one to share that with our viewers.
Well, I think that the major thing, Tony, is for people to have choices. And I am not here to say that hospice is for everyone, because for some families it's not. But for those families who choose to care for their family member primarily at home and who need that support system to be able to do that, and to be able to, our motto is to be able to give life to every day when the days are numbered. And so I think that it's an opportunity to have another choice and to be able to have some quality in that choice.
I would like to continue on that path for a moment. Isn't it true in this country that there is a growing number of people who subscribe to the philosophy that once terminally ill and you cannot really do any more intensive care at the hospital, that there are two real basic reasons to go home. There may be others, but two that are very paramount to the whole family. And one of them is by going home, and if you have 2 months left or 3 months left, to be able every day to spend that with members of your family rather than they come into the hospital for an hour's visit, that's a special kind of quality, that there's a special time that's not lost. I know one member of a family who had a patient with hospice told me that with great emotion, he indicated, he said, because of hospice, I was able to have 3 months on a daily basis with my wife. Without hospice, I would not have had that precious time. Am I correct that that is one of the primary purposes of hospice?
Yes, I think it is, and to be able to give the family support and helping them to talk about how they feel and to really have a real closeness. Lots of our patients and families say that it was kind of a gift to them because they learned how to talk to one another openly and honestly and had time to share the things that we have all put off doing. And so that really is a true gift that family members can give to one another.
And a second factor, and after the death of the loved one, the family must go on, and you have financial responsibilities and burdens. And I've had members of families to tell me that there were in certain economic situations that if the member of the family would have had to have remained in the hospital, that it really truly would have cost thousands of dollars that they did not have, and they would have gone into debt and had a burden of trying to pay back over a long period of time. And because they were home and it was far less expensive, that they came out of the what was already a traumatic experience, at least not in debt financially. So that is another asset to hospice, isn't it?
Yes, and I think many insurance companies now have kind of caps on how long people can stay in the hospital. So I think that it's an option for hospitals to be able to use hospice too.
And I know around the United States another policy of hospice is that what you've been talking about, the total care of the patient and then the concerns of the family. But could you take a moment please, to tell us that there are special times. I know in our case, I think it's on Friday mornings, but there are times when all of these special people who are serving that client or patient gather together. I believe there's a team meeting. Would you tell our viewers how that operates to give the ultimate quality care to that patient?
I think hospice gives more than just lip service to the fact that we are interdisciplinary. And so on every Friday morning we meet with the physician if they're able to attend, and it is so valuable to have the family physician in attendance. And we meet with the director of nursing and the nursing staff and the director of social service and all of the social workers, our grief counselors and our physical therapist and our speech therapist and our occupational therapist, our minister and the pharmacist when he has an opportunity to be there, which he tries at least to be there once a month, and our grief counselor. And then we have a very special person who is our medical director, who is totally volunteer, and he coordinates the team meeting, and they all work together to make a plan of care that is most appropriate for that patient. And then the volunteer is also in attendance so that they can understand how that whole teamwork is fitting together and interfacing each discipline with the other so that we don't duplicate the other services, and so that we augment at every moment the quality of care that is offered the patients. And then once that is set into place, then it is signed by the family physician and our medical director, and then it is taken to the patient and discussed with the patient and the family to see if in fact this is how we might best be able to serve them, whether that be a home health aide coming in and helping bathing 2 or 3 times a week, or whether that's the social worker setting up a family conference, whether the minister is contacting their minister and getting their minister active in their family life at home rather than through the the family coming to church. Often the minister then will begin to come to home. So it really is a very fine way, I think, of being able to address the patient's needs and the family's needs in a way that is most comprehensive and provides the best quality of care.
And I know there's some difference from hospice to hospice around the country. They don't have to be identical. I'm not talking about the care now, but I'm talking about some other additional benefits of the organization. They have their own traditions and so forth, like a family does. I know one that at North Idaho that's very important is that there is an annual service. I want you to tell us about that, but also give us some insight to other hospice. How do they bring families back together after periods of time so there's some kind of unity among all families that have had someone with hospice? I think that's a very important part of our life is, I don't know what term to use for it, but some formality, some ceremony, some way of recognizing, not only in this but in other things in life. Tell us about how hospice deals with that.
Well, that is a real important part of surviving family members, is to be able to have some connection back with the people that have cared for their loved one. We have 2 times a year that we do that. We have one in May, usually. This year it'll be in June, is a memorial service that really celebrates a time for family members to be together and to grieve together, and the family member being inclusive of all hospice family people who are surviving, who live in this area. Some people come from Seattle, We had one family member come from Georgia last year to attend that service. It is really quite a healing service, and it's non-denominational and is very, very meaningful to the families that participate. The other time that we have that is at Christmas time, when we light a tree in our community, and I think most of the hospices in the Northwest now have had the opportunity to begin to give that as a gift to their community. It acts in two ways as a fundraiser, but that's not the primary reason that we have it. It is a way of having a tree lit during the Christmas season to be able to recognize the people that we love and care about in our families. And it doesn't necessarily have to be a person who has been in hospice. We had one grandmother who said to me not long ago, "It is the only gift that I ever had and was able to give to my granddaughter who was born dead." And so what a nice thing to be able to remember her at Christmas. So those 2 times a year, and most hospices I think now in the Northwest have had the opportunity to do the Christmas celebration. We were real fortunate to be the first one in the Northwest to be able to start that tradition, so that's nice.
So many people's lives are affected by what I believe is this very, very special service. Could you take a moment to share with us, and again, this would be appropriate around the United States because there would be people and they would have the same experience without revealing any privacy, of course. Is there any particular example you could give us of how either a patient or a family has been so touched by, I know some myself where some of our people, our staff, and our volunteers have done some very special things that person had never even experienced in their life. So what you're talking about, quality time that you have left, that each day is so special. How can we light up the life of someone in those times?
Well, I think, just doing the simple things, give people the opportunity to be able to experience some things in the last few months of their life, the last year of their life, that they've always wanted to do and have never been able to take time to do or haven't found that time. One thing that comes to mind is a patient who wanted to learn German. And so we had a volunteer who came forth from the community and said, "I have this skill and I would like to share it." And so that was an exciting time when they were able to order off of a menu when we went to dinner one evening, things in German rather than in English. Another opportunity was to have an instructor teach a person how to balloon. And they had never flown a hot air balloon, and that was something that they wanted to do before they died. And we were able to help facilitate making that happen. Another really exciting thing that happened was a patient of ours who is kind of the epitome of what hospice hopes to stand for, and that was a patient that went to Canada after much stress. The airlines didn't want to take her because she was on 24-hour oxygen, and to get her through customs was very difficult. So we networked with the hospice in Vancouver, British Columbia, and their staff came and physician met her at the airport at customs, and they got her all the way through customs. And it was because of her volunteer, I need to add, that all this was able to happen, because she believed that nothing was impossible. And when the first airlines said no, she just went to many more airlines, and then a wonderful travel agency here in our community also helped. And when she got to visit her son, which that was her destination, was to visit her son, it was clear back in the outskirts, no one had seen portable oxygen. So the physicians came to visit her and the medical people came to visit her, and because of her visit, they then initiated home oxygen, which they had never had in that community before. So the gift that she left behind was mobility for many, many people in that community. So that was a real gift and a legacy to her.
That's a very special story, and I wanted to get some of those before our viewers, because that's, again, another one of the real great qualities of hospice. We've talked a lot about the different people who serve the family and the patient. Obviously, you as director, you have a very good background, and you have experience in the medical field and are a nurse, and all of our nurses, of course, are trained and certified. But the volunteers we've been talking about, what we have not done yet is inform our viewers that they don't just come into the office, sign up, and the next day they have a patient. Everyone involved with hospice has special training. Could you tell us a little bit about, not only here, but in hospices all over the country, they are policies and booklets, and what does a volunteer go through before they become a really caregiver for hospice?
Well, I think that they're our most dedicated people in hospice. I truly believe that. They have a 56-hour training session that it's mandated that they come to. They're only allowed to miss 3 hours of that 56 hours and still graduate. And if they miss that, then they have to watch the video or listen to the tape of that session to make that up. Then after that, they have an interview with our volunteer coordinator and with our director of social service to make sure that they are indeed wanting to make this commitment. They have an in-service once a month that they're required to come to, and they have a support group that they're required to come to twice a month. So just the meetings alone require a great deal of their time, and then we require that they're willing to spend 4 hours a week with the patient and the family. So for our volunteers, that's really a huge commitment they're making. I do believe that we probably have one of the very best training sessions. We choose people who are excellent from our community and who are the very best at physical therapy, at counseling skills, at understanding patients with special diseases. We have several physicians who come and speak. And so we don't try and provide that ourselves as staff, but we have people who we feel are the very best in our community and in Spokane come and share their information with us.
But you're bringing people in during those classes from all those fields, like you're saying, to deal with the whole aspect of the patient and the family that they will be dealing with later.
Yes, we have the psychosocial, the spiritual, and the physical. Also,
isn't there a rather large booklet that you've developed that each volunteer has to take, and they read and study that also, as well as the lectures themselves?
Yes. And I think that, you know, now because we feel that the volunteer is such an important part of our program and to have them well educated, we also they have found at the national level to do some standardization of the courses that are taught to volunteers.
I'm so sorry to interrupt. We're out of time. On behalf of the staff, it's been a special delight having you here, Kay, and you've been most informative as always, and it's a wonderful organization. Ladies and gentlemen, our guest has been Kay Magruder, who is the Executive Director of Hospice of North Idaho. She's also the President of the Council of Idaho Hospice Organizations and is on a national committee of the National Hospice Organization. Once again, we want to say that this is a very, very important and fast-growing organization around the country, and would urge families to look into this service if they need it. I would like to invite you to be with us again next week at the same time when we will discuss an important subject, and until then, please have a good week. I am Tony Stewart.
North Idaho College Public Forum can be seen at the same time each week over this station. This production was videotaped earlier by an NIC student crew for viewing at this more appropriate time.